Hi guys, just trying to make sure you're still awake, alert, as what follows is really important.
I'm referring to determining whether your patient with a neurological problem, in particular motor weakness, has an upper motor neuron lesion or a lower motor neuron lesion. You probably have seen this table before, but don't panic. Let's push this aside first. Let's take time to dissect it. When you say upper motor neuron, we refer to the neurons in the cerebral motor cortex. There you are, this is the motor cortex. Okay, responsible for voluntary motor movement. This upper motor neuron is the origin of the descending neural fiber tracts that goes down to end in the spinal cord. It's called the corticospinal tract, or it can also end in the motor neurons of the brainstem, cranial nerve nuclei, and we call that tract the cortico-vulvar tract. Now take note that any lesion that would affect the upper motor neuron and its descending tract just before its synapse with the anterior horn cell of the spinal cord or the cranial nerve nuclei of the brainstem will produce clinical manifestations that are referred to as upper motor neuron lesion. Patient can have spasticity, hyperactive reflexes, Babinski, among others. We'll get to that. On the other hand, when you say lower motor neuron, this would refer to the anterior horn neurons. There you are. That's the anterior horn neuron there. Anterior horn neurons, okay, of the spinal cord or the motor cranial nerve nuclei. These neurons give rise to nerves that ends into the muscles of the limb and voluntary muscles of the face and the neck. Now, anything that would affect the anterior horn cell of the spinal cord and their corresponding nerve, myoneural junction, and muscles can produce several clinical findings which we refer to lower motor neuron lesion. So let's try to dissect them. When it comes to type of paralysis, patients with upper motor neuron lesion have spastic paralysis compared to the flaccid paralysis of patients with lower motor neuron lesion. The tone of the muscle, when you passively move the limbs, okay, then you feel hypertonicity in patients with upper motor neuron lesion, but hypotonicity among patients with lower motor neuron lesion. Matigas po ba ito? Reflexes. Okay, use your hammer, your favorite hammer. And patients with upper motor neuron lesions have hyperreflexive reflexes, at times with clonus, while on the other side, lower motor neuron lesions have hypoactive to areflexia. Okay, so no clonus. You don't expect any clonus. Patients already with no proper innervations of muscles, or if it's unused or disused, then you can have muscle atrophy. You have a disused type of atrophy in patients with upper motor neuron lesion, but the atrophy is more severe and prominent and even early among patients with denervation atrophy seen in lower motor neuron lesions. Now, What are fasciculations? Fasciculations are actually spontaneous contractions of muscle fibers causing flickering of movements under the skin. Okay, and that's usually happens when the muscles are not properly innervated by a nerve. Okay, then it would have spontaneous contraction. Well, you see positive fasciculation among patients with lower motor neuron lesion. You don't expect to see that, or it's absent among patients with upper motor neuron lesion. And when you do your testing for Babinski or the plantar reflex, there is an upgoing toe. If you see an upgoing toe, okay, or a positive Babinski, think of upper motor neuron lesion. You don't expect to see an upgoing toe or Babinski in among patients with lower motor neuron lesion. There you are. Okay, we have the summary. So among patients with upper motor neuron lesions, these are the findings that you would like to see. There is spastic paralysis, a hypertonic tone, hyperactive reflexes with or without clonus, a disuse atrophy, no fasciculation, and an upgoing toe. On the other hand, among patients with lower motor neuron lesion, you would see patients having flaccid paralysis, hypotone, poor reflexes or areflexia, but no clonus, a marked atrophy, particularly called denervation atrophy, positive fasciculation, and negative or no plantar reflex. Localizing and being able to solve the puzzling problem of a patient with neurological illness can really be challenging, but can be very, very rewarding. Maybe you can try this. Think of very big major highways like the EDSA, okay? As long tracks with one side going southbound like the corticospinal tract and opposite going northbound or upwards as the ascending spinothalamic tract. Now, the smaller avenues that exits or enter the main avenue are the major motor and sensory nerves of the upper and lower extremity. Okay, based on patient signs and symptoms, okay, and the results of your neurological exam, you determine which area is affected. There you are, you have several nerves there, cranial nerves and the root nerves of the trunk and the lumbar area. Okay, there you are. Okay, so you look, are there intersections of long tracts and shorter motor or sensory nerves? Okay, so again, trying to summarize that thing there. Okay, think of main avenues. There you have the motor, the sensory, proprioception and vibration fibers. Okay, think of the major streets along EDSA like Cubao, Ortigas, Show, Ayala. Okay, these are the horizontal sections or the exiting pathways. This can be the cerebral cortical, in the cerebrum, the cortical functions, particularly the homunculus. The brainstem, you have the exiting cranial nerves. That would define the level. So if you have a third nerve, think of the midbrain. If you have a 5, 6, 7, 8 nerve, cranial nerve involvement, think of the pons. And 9, 10, 11, 12, think of course of the medulla. Okay, and think of the cortu. Remember the exiting roots. Okay, the dermatomes would define the level. Okay, look for intersections. That's the point there. Look for intersections that would explain the source or the location, the reason for the signs and symptoms. And by the way, don't forget to look for neighboring signs. Okay, are there other signs and symptoms, dysfunctions near the suspected lesion that will further support your localization?
Okay, there you are. Take that away. Okay, there. Okay.
When it comes to localization, it is important that we master several tracks, okay, because this will help us greatly when we try to localize where the problem is. And and the three major tracks that I'm referring to is, number one, the descending tract, particularly the cortico-spinal tract. Okay, this is responsible for voluntary motor function. Okay, the corticobulbar tract is a little bit shorter because it ends in the brainstem, starting from the motor cortex to the different cranial nerves, neurons. Now, the second one would be the ascending tract, the spinothalamic tract. Okay, that's responsible for pain and temperature. Okay, so take note of the decussation. We'll show that later. And then the third one is another sensory tract, ascending tract. That's from the posterior column tract, which is responsible for position and vibration sense. Okay, your question would be, where do these tracts start? What parts of the cranial of the central nervous system does it go through, and where does it end? Okay, try to know that. Well, this is one. There you are. Let's talk about the lateral corticospinal tract. This is motor. Take note at the level of the decussation. It's at the pyramidal part of the medulla. That's in the cervico-medullary junction. So, from the cortex, it goes down, and at the level of the lower medulla, it crosses to the opposite side to innervate the contralateral side. So, that's the pyramidal decussation. Now, the posterior column pathway, which is responsible for position and vibration sense, and as well as fine touch too. Okay, now these are ascending fibers, of course, and they would cross at the lower part of the medulla. It's called the internal, wherein they are called the internal arcuate fibers as it crosses to the opposite side. So the decussation is up there in the lower medulla. Okay, now the anterolateral pathways is also involved for sensory. That's pain and temperature, and also touch, but this time crude touch. Okay, now they would cross at the level or one or two level above the entry, anterior to this remnant of the spinal canal. It's called the anterior commissure. Anterior commissure. So try to memorize this, okay, because these are important pathways. Now take note here. There are 5 basic modalities of sensation. We're referring to vibration, position, light touch, pain, and temperature. So again, for vibration sense, that's through the posterior column. These are large fibers. The joint position sense, okay, that's also posterior column. These are again large fibers. Now, when it comes to temperature, that's the anterolateral spinothalamic tract. Okay, small fibers too, medium. Pain is small fibers through the anterior spinothalamic tract. So, both the pain and temperature recorded by the spinothalamic tract. The pain is anterior while the temperature is anterolateral. But take note of light touch here. Okay, the light touch fibers, their sensation is carried both by the posterior column tract and the anterior tract. They are coursed through both the posterior column and the anterior spinothalamic tract. So for that very reason, because light touch sensation is carried by 2 tracts, it is not very helpful when you want to localize, okay, where the lesion is. Thus, light touch for the trunk and limb is not routinely done. Okay. However, when it comes to the face, then this is not true because you really have to examine that. These are special senses. You ask yourself, can the patient's signs and symptoms be localized to one site? Is it possible the problem is not just a single lesion, but would involve more than one part of the nervous system? Well, that brings us to our second type of localization, and that's the type localization. Type localization identifies the type of dysfunction present within the nervous system. It refers to whether the location of the lesion that would explain the patient's signs and symptoms can be explained by involvement of one part of the nervous system or by several sides, or maybe it cannot be explained as there is a diffuse involvement of the nervous system. Type localization can be derived after doing your history and neurological examination and deciding what part of the nervous system is or are involved. But of course, just even as early as history taking, you can have already an inkling of what part of the nervous system is involved. So, the lesion can be focal, okay? Oops, better get out now. It will be focal, multifocal, diffuse, or can involve a specific system of the nervous system. A focal lesion is one in which a single discrete neuroanatomical locus can account for all the patient's symptoms and signs. For example, in a patient with sudden onset of right hemiplegia and aphasia, okay, that clearly speaks of a left cerebral hemisphere involvement. You can explain that, well, because that's a focal lesion. A left cerebral hemisphere infarction or stroke. A patient with headache, amenorrhea, bitemporal hemianopsia, particularly, of course, in a lady, okay, then this can be due to a pituitary tumor. Okay, another one would be a patient coming in with numbness on the first 3.5 fingers of the right hand and weakness of the right abductor pollicis brevis. Think of a right median neuropathy. So this is a mononeuritis multiplex. Okay, so think of a focal lesion because you can explain everything just on one location. Now, on the other hand, you think of a multifocal type of lesion, okay, when you cannot explain it with just one locus. Okay, if it's there are two or more different sites that can explain your patient's problem, then you may be dealing with a multifocal lesion. For example, okay, among patients with atrial fibrillation, a cardiac origin of embolization, okay, a patient can present with sudden onset of right hemiplegia and aphasia, suggestive of a left cerebral hemisphere dysfunction, but also you see a finding of a new onset left hemianopsia. Okay? And that would mean this is an involvement of the opposite or the right temporal or right hemisphere. You can't explain that by one lesion. So patient has a multiple type of localization. Patients with Bell's palsy, that's due to left facial nerve paralysis, but at the same time has a wrist drop on the right due to trauma. Okay, then you have to think of two lesions here. So think of a multifocal lesion. If you are not able to localize the lesion in discrete areas of the nervous system, the problem can be due to a diffuse lesion. Okay, a widespread dysfunction of parts of the nervous system or the whole nervous system. Like among patients who had a cardiac arrest, who is now comatose, okay, you see numerous signs and symptoms. This is suggestive of a diffuse involvement of the brain. Okay, or a patient with diabetes complaining of distal extremity numbness in a glove and stocking distribution pattern. This is due to diabetes. This is also called a diffuse type of lesion. Well, note that in both multifocal and a diffuse process, there is involvement of more than one discrete physical lesion. But in multifocal, the lesion remains discrete, whereas in diffuse, the dysfunction is generalized. In the example of numbness and pain in a glove and stocking distribution, okay, in this case of neuropathy, for example, a multifocal process will be evident by signs and symptoms in the distribution of multiple specific nerves, like median nerve, ulnar nerve, femoral nerve. Okay, some nerves are involved, some are not. But in axonal neuropathy, okay, a form of diffuse nerve disease, okay, the distalmost portions of all axons are involved, resulting in glove and stocking distribution of both sensory and motor loss. The last one, it's called a specific system type of involvement, is a subset of diffuse localization. In specific system process, there is diffuse dysfunction of a particular pathway or neurotransmitter system. For example, in Parkinson's disease, you see patients with tremors, bradykinesia, and rigidity. Okay, and this is due to a dopamine deficiency. So this is a neurotransmitter problem. It seems to be diffuse, but attributed to dopamine deficiency. On the other hand, the progressive diffuse weakness, the atrophy, fasciculation, and spasticity in ALS, or the amyotrophic lateral sclerosis, can occur because of loss of anterior horn cells and degeneration of the corticospinal tracts. So they may seem diffuse, but this is related to a problem in the corticospinal tract and the anterior horn cells.